Pharmacy Strategies to Address New and Old LTC Scenarios. Guest speaker is Matt Penner.
Cool. Yeah. So this, as you guys all know, this conversation and the CME for tonight is something that we've been planning for the last couple of months based on conversations that we had all had regarding some of the different learning topics that we were hoping to learn about. So we've invited Matt from Northcrest to come in and talk about pharmacology in long-term care. For those of you who haven't had the pleasure of meeting Matt yet, he has been a practicing pharmacist for over 15 years in a diverse setting, consisting of long-term care as well as mental health and addiction work in Vancouver's downtown east side. Outside of work, he is an avid outdoor enthusiast. So Dr. Luck, maybe you will get your pickleball partner. You and Jody can start your team together. And he also enjoys hiking, climbing, or canoeing on multi-day trips. And Matt, I may have just signed you up for pickleball. So that's right. I'll circle back with you later.
I hope you can run faster than I'm sure.
But here's something that we can, I thought this was really impressive. He likes to practice Olympic weightlifting so he can be independent for as long as possible. I was actually really impressed with that. Olympic style weightlifting is no easy thing to do, so pretty impressed. But Matt, we are excited to learn from you this evening. We'll hand the conversation over. Thank you so much for joining us tonight.
Yeah, thank you for inviting me and thank you for having me. I just want to make sure, can everybody see this screen now, the title page, and hear me all right? Just some head nods, hopefully. Great. So I wanted to address some different pharmacy strategies on how we can address some of the common scenarios that we see or encounter in long-term care. I use the phrase patient and resident often interchangeably, and you may hear me switching back and forth, and I use the phrase home or facility interchangeably. You may hear me referring to them back and forth, but please keep in mind that I'm talking about a long-term care setting. And if you have an office where you see patients who might be older individuals, but they're coming into your office, they're still independent, or if you are even seeing patients in an assisted living situation or setting, some of these recommendations might not be as strong as I'm suggesting here, because I'm considering a long-term care setting for that. I have no conflicts of interest to declare. The objectives I've changed slightly from what was on the agenda that was circulated to you. As I was going over this, I found it was going to take far too much time to go into the amount of detail I was hoping to provide for a number of the different topics. So I've limited it today to how we can have conversations with family and nursing staff surrounding the timing of different medications, to review, again, some pharmacy strategies to decrease antipsychotic use, review some pharmacy strategies to reduce polypharmacy. I want to put the emphasis on the pharmacy part there because there has been a number of physician-led deprescribing and polypharmacy education sessions even within the last month. So I will not add much to what you have already heard probably multiple times, other than to put my spin or my pharmacy lens onto that. As a prescriber, you are probably familiar with your prescribing practices, maybe the prescribing practices of the other physicians in facilities or homes that you visit. I get to see the prescribing practices of a diverse group of physicians. In that same view, I am a single pharmacist and I haven't sat in with other pharmacists on how they do their care conferences or medication reviews. So there might be some differences there as well. Finally, there were some submitted questions for common prescribing scenarios. And so I'll address some of those for you as well. The timing of administration of medications has come up a lot more over the last year than it has in previous years for me. A lot of it is surrounding Cinemet. I've had more than one family asking nursing staff, asking myself to provide them with printouts of electronic MARs, because of course with electronic MARs nowadays, it's recording exactly the minute that a nurse administered a medication. And so many times these family members, if they're noticing dyskinesias, dystonias, if they're noticing any of this on-off phenomena, they're saying that it's the fact that the nurse has not administered the medication precisely at 1 p.m. or exactly at 7 p.m. that's contributing to that for their loved one. Many of these side effects, Parkinson's disease is a progressive disease. As much as 40% of patients will develop these symptoms within 5 years of starting therapy. I would suggest, but by the time residents end up in long-term care or your patients end up in long-term care, they've likely been taking Sinemet for longer than 5 years already by that point. So it's very possible that we're seeing these as a normal progression of Parkinson's disease. Nurses normally have a 1 hour window surrounding the timing of administration of a medication. So if it's scheduled to be administered at 8 o'clock in the morning, they have roughly from 7 to 9 a.m. to administer that medication. When it comes to Sinemet, it's generally accepted that that window should be much tighter, around about a 15-minute window. Not every family member will be happy with that. Many expect their loved one to receive the medication within seconds or minutes of the prescribed time, but I think a 15-minute window is realistic. If we consider the pharmacokinetics of Sinemet, its peak level is approximately 30 minutes after administration. It's going to last for approximately 4 hours. So by the time if we are late in administering those medications, it is possible that we would be seeing more side effects or symptoms of a resident's Parkinson's disease. There are a number of things to consider if we're noticing more of these side effects and families are wanting to have this conversation and are believing that this is surrounding the timing of that medication. I would consider if this individual had been started on an antipsychotic recently. Sinemet is a dopamine agonist, and most of the antipsychotics are dopamine antagonists, so they have an antagonizing mechanisms of action. Iron interacts with Sinemet, forming a clump that's not going to be absorbed, so there would not be as much Sinemet there. Metoclopramide is strongly associated with Parkinson-like symptoms. This correlation can occur in as little as 1 to 2 months. You would start to see somebody having Parkinson-like symptoms after starting metoclopramide. In the era of polypharmacy, it is reasonable to think of prescribing metoclopramide for a short duration of time to help your patients if they do need something. Less than 1 month of duration of treatment with metoclopramide was not associated with a significant risk of Parkinson's symptoms. Residents who eat high protein, high fat, high calorie meals, people who are eating a lot will have less absorption of Sinemet. Conversely, patients who are not eating as much will have more of an effect from their Sinemet. Carbonated beverages increase the amount of Sinemet. Crushing Sinemet helps. I will often get the question, is controlled release an option then to help or offer to families? I don't often recommend a controlled release formulation, given that the general trajectory of our patients in long-term care is that many, if not most, if not all, will end up with swallowing difficulties or dysphasias of some sort, requiring usually a fairly quick conversion of their controlled release back to an immediate release one so that nurses can crush those medications and administer them. As a takeaway for Sinemet, if you're talking to families, I think a 15-minute window is reasonable, and your input or your education, as brief as it could be, would help families to understand some instances that Parkinson's is a progressive disease and we're going to see these phenomena. I continued on to look at the timing of other medications that often come with specific dosing times. So PPI timing of your rabeprazole or pantoprazole. Hospital discharges will usually indicate that it should be given 30 minutes before a meal. They are not wrong. With that being said, that treatment is usually, that timing is more important if we're talking about treating an ulcer, if we're talking about treating H. pylori. In long-term care setting where somebody is receiving a long-term PPI, the timing is unlikely to make a difference. If we will go further into this as we're talking about polypharmacy, PPIs or medications we would highlight as being potentially ones we could remove. For bisphosphonates, it is important to have these 1 hour before a meal on an empty stomach. They have very poor bioavailability, and it can be decreased significantly by as much as 60% with any food or beverages. What many nurses do recognize that bisphosphonates should be taken on an empty stomach and do that spacing. What I'm seeing on electronic Mars is if somebody has medications that are ordered 30 minutes before a meal, going back to, say, for example, a PPI, many times that medication is being given at exactly the same time as the rest of the 0800, 1200, or 1700 hour medications, as the nurse does not have time to administer a medication, see some more patients, and come back to administer the rest of this person's medications. While I speak briefly about bisphosphonate timing, I wanted to mention that bisphosphonate is one medication that has a defined treatment period where we could look to discontinue bisphosphonates after 5 years of treatment. After treating somebody with for 5 years with a bisphosphonate, their risk of fracture is not decreased further if you continue treatment for another 5 years. So after 5 years of treatment, you will not see an additional benefit of that medication in your patients. So 5 years is generally where I'm recommending we can discontinue that one. If you're using agents like domperidone or metoclopramide for gastric motility, yes, we want to take those 30 minutes before meals because we want them to be in our system and giving that beneficial effect by the time somebody is eating. If we're using those medications for hypotension, it would be less important surrounding the timing of those. Synthroid is another one that will come up. We know it has many interactions with food or medications. Hospitals will often dose it at 1000 hours. In a long-term care setting, I would suggest that it can be given at the home's standardized medication times. Many facilities will have a 0800, 1200, 1700, 2100, or 2000 hour standardized medication dosing times. And I would suggest it is appropriate to use Synthroid in those times because we can manage these effects. We can measure the TSH. It's going to be consistent that the nurses are giving it at approximately the same time every day with the same medications every day. So we have that consistency to be more comfortable in managing that interaction. If I have learners, students, new pharmacists who are starting at the pharmacy, quite often people are very happy to catch a drug-drug interaction and say that this individual is taking their Synthroid at the same time as their morning calcium dose. Oftentimes, if you see that, those residents who are taking calcium and Synthroid at the same time, their Synthroid dose will be 100 micrograms, 125 micrograms. It's not the 25 to 50 micrograms we might see for people who are not taking it at the same time as a medication that's going to decrease its absorption. When we talk about medications for BPSD, timing could be important if there are specific behaviors or triggers, if we're talking about sundowning, if we're talking about particular times of the day where behaviors tend to be worse for residents. There is this is a good opportunity to switch now into speaking about antipsychotics in a long-term care setting. Antipsychotics are one of the quality improvement indicators that we receive reporting on. It is looking for residents in long-term care who may be taking antipsychotics inappropriately. We know that there is a black box warning by the FDA and Health Canada, which is the strongest way they can convey a message or a warning about a medication. And That black box warning is in place because using an antipsychotic for an elderly patient with dementia does increase their risk of death, which is a pretty poor outcome. What is scary about this is that this is what the media likes to grab on. So as those qualities indicators are available to the public, you will have different media articles like the Toronto Sun posted an article, and I'll read here quickly. This was the first paragraph of their news article. Use of antipsychotics is soaring at Ontario nursing homes. Powerful, potentially lethal drugs are used off-label to control behavior among dementia patients at alarming rates in some homes, despite warnings that this medication can kill elderly patients suffering from dementia. That's the first paragraph in that article. It does not provide the context or the nuances. It just presents that information. And if a loved one is reading that, whenever these articles are published, I notice at care conferences for the next month or so, if CBC posts an article, Vancouver Sun posts an article, the province posts an article, the next few weeks at care conferences we will have families asking, is my mom or dad on an antipsychotic? If you look at the prescribing information for quetiapine or risperidone, it will mention prescribing these medications for BPSD, that it's off-label, but they go on to say it could be used for agitation or aggression and psychosis associated with dementia, severe or refractory. In patients without a clinically significant response after an adequate duration of treatment, which they're suggesting is about 4 weeks, consider tapering and withdrawing therapy. Only continue in patients with dementia that have an established or clear benefit, and even then attempt to taper or withdraw at regular intervals. Patients with dementia and Lewy bodies are at an increased risk of serious adverse events. Caution is required. So the information is out there that we should be using these medications quite sparingly. And that's why they're consistently being reviewed in these quality indicators. I talk quite often, mostly to nursing staff surrounding this, because we understand the risks and the associated harms. I think sometimes there's a communication gap between care staff. So they may see or may have seen, or the culture may have been in the past, that when they have patients who have difficult to treat behaviors, the nurse sends an SBAR, and under the recommendation, they're asking you for some quetiapine, maybe even recommending a dose for you. I'm trying to educate them that as the first line, there is a lot of harms associated with this. They need to provide you with the information so that you can make a decision surrounding these patients. So this has worked well in the past, giving out posters like this for nurses. So behaviors that absolutely will respond to an antipsychotic medication are, of course, delusions, hallucinations, or if there's physical aggression, agitation, or harm. There are behaviors that may respond to antipsychotic medications. We use them as adjuvants for agitation, for a depressed mood, for anxiety. Are there potentially other medications that could work better for these conditions? Yes, those should be explored first before prescribing an antipsychotic for any of these indications. And then finally, behaviors that will not respond to antipsychotic medications: hoarding, inappropriate dressing or undressing, screaming or repetitive thoughts, speech, wandering. If somebody is fidgeting or nervous, inappropriate voiding, spitting in a corner. I wish we had a medication that you could give to help for these, but it's not going to be an antipsychotic. When I'm talking to nurses, when I'm talking to care staff, they often believe that antipsychotics do work for these conditions. And I think that comes from the sedative properties of the antipsychotics may put that resident, that patient, into a drowsy state where they are no longer showing these behaviors, but it's not because we've removed the underlying cause of those behaviors. It's because that resident or is now drooling while they're sitting in their wheelchair. I mentioned these and I point these out because as you are prescribing antipsychotics, one of the strategies that I will get to is including the reason you are initially prescribing that antipsychotic. That is going to make my life, that is going to make your life a lot easier when we're at the care conference or the medication review, talking about those medications and trying to remove them. Very common, I will hear nurses, care staff describing an individual saying to the family at a care conference, they're absolutely lovely. They are helping us to fold hand towels, to keep busy. And so then it comes to me at the pharmacy to talk about the medications. And I say, hey, maybe now is the time that we can decrease, stop, or discontinue this resident's quetiapine. And usually quite quickly, care staff will put up their hands and say, well, don't you remember 6 or 7 months ago, it was a disaster. It was very hard to deal with this resident. And that could be very true. Dementia, Alzheimer's disease is also a progressive disease that has different behaviors presenting at different times in the trajectory of that disease. So if somebody has a particular behavior at a particular point in their disease journey, and we treat that with an antipsychotic, it does not mean that that particular symptom that we were treating will necessarily be present forever and ever. It also doesn't mean that that resident will not decompensate and have new behaviors. So if we are highlighting the target behavior that the antipsychotic was originally prescribed for, it's easier then to remove it later instead of saying, well, generally this person is doing well. I don't have any behaviors to tell you that have been improved because generally they are doing well. Antipsychotics are an area that has evidence and guidelines for deprescribing. If anybody has been to deprescribing.org, there's 5 different conditions they list where they have summarized the available evidence into relatively easy to follow algorithms like this for deprescribing antipsychotics. I'm not going to focus too much on this right now, other than to point out that they're suggesting that all antipsychotics attempt to be discontinued or decreased twice for every resident. So we attempt to decrease or discontinue for a resident and behaviors come back. We restart the medication. That doesn't mean that that person should again forever and ever and ever be on that antipsychotic. We should attempt that withdrawal again at a future date. The prescribing information in the CPS or LexiComp is suggesting 4 months is a reasonable time frame. If we have care conferences or medication reviews scheduled every 6 months, I would suggest that that would also be a reasonable time frame. In between these, I would encourage you to feel empowered to also look at and assess that and look to be discontinuing those medications. This is absolutely an area that I recognize it is very easy for me as a pharmacist to say, best practice is to decrease, eliminate, discontinue these medications. You're the face of that recommendation for me to families and to nursing staff. And it's the nursing staff that will be with that resident if they have that repeat behavior coming back. If that antipsychotic was working very well for that resident, we've taken it away. They are the ones who have to deal with that resident and have particularly a difficult night. For that reason, some of the strategies that I'll recommend that can help to make nurses and care staff feel more comfortable with this is to add on whatever we are taking away as a PRN. It can still be administered. They don't need to contact you. They could still give the same dose that this person had been receiving regularly before. And now we have the opportunity to assess or evaluate the PRN use moving forward. And a PRN antipsychotic is easier to discontinue than a regular. Other strategies I see or think could be helpful from a pharmacy perspective would be, I recognize that when many care staff feel the need to inform you as prescribers about many common scenarios or behaviors that the residents are showing. Many of these are unlikely to be meaningful for you. I use the example when talking to nurses, everybody can have a bad day. And I use myself as an example. If I don't have a good sleep, I can be a bit of a grouch at work. I can be a little bit more short with my colleagues. I believe that our residents should be allowed to have a bad day here or there. But I recognize as well, the nurse has taken the time to write this SBAR to you. Maybe they've even recommended an antipsychotic for you to prescribe. And that may put a little pressure on you to now respond to that behavior. For that reason, I would suggest that as nurses are writing you these SBARs and they're recommending antipsychotics for you, you can see the situation and the background that they've provided for you. And if it is an agitation or aggression, a psychosis, a hallucination, a delusion, it would be appropriate to start that antipsychotic. Please include the indication so that, again, in 1, 2, 3, 4 months, in whatever time frame, we can review and address for that specific cause that we started that antipsychotic. Alternatively, if it is your patient pushed away the care aid while they were trying to be showered today, if it says this person is wandering plus, if this patient is agitated plus, what does that mean? Ask them for to do a behavioral log. And if every time they are asking you to prescribe an antipsychotic, you're asking them to do a behavioral log, it may influence the culture of that home where nurses will feel more comfortable managing less severe behaviors on their own prior to having to start a behavioral log for a resident whose behaviors may not warrant them wanting to do this extra behavioral log for the next 3 days or week. Cannot stress enough, including the target behavior or the reason starting the antipsychotic, using that in the indication. If you write quetiapine 12.5 milligrams BID, pharmacy will type quetiapine 12.5 milligrams BID. If you write for agitation, almost always pharmacy will include that. And then when we're at the care conference or medication review, we're seeing that target symptom. Another consideration, I don't see this very often, but I have seen it used, is prescribing for a reasonable time frame and including your discontinue or reassessment date. So saying quetiapine 12.5 milligrams BID for 6 weeks and then stop, including the discontinue already as you are prescribing the medication. I put reassess as a question mark there. Reassess is can be culture dependent for the home or even the pharmacy that your facility deals with. What I mean by that is I hope that my pharmacy colleagues would not, if you've written to be reassessed by this date, there are medications I would not want my pharmacy colleagues to immediately discontinue, and there are medications that I would want my pharmacy colleagues to not continue to send until you had reassessed that person. So those could be options or ideas to help decrease starting or continuing. This would be a good opportunity to move now to polypharmacy. So polypharmacy is bad. Now what? There is no generally universal agreed upon definition of polypharmacy. Europe uses a definition of 5 or more medications. For us, Fraser Health, we're using inter-RI data that's collected, and their definition of polypharmacy is 9 or more medications administered within the last week. So that includes your once-a-week vitamin D, that includes your once-a-week alendronate, and would include if somebody ended up on bowel protocol and needed an extra Senicide, if somebody had a headache and received a Tylenol tablet from standing orders, that would then count towards those medications being recorded or captured. Again, with all of the recent polypharmacy presentations, workshops that have been going on, I'm not going to delve too far into the numbers as to why polypharmacy is so important, other than to say that with the increasing number of medications that you take, Beyond 4 medications, it's an exponential increase in the amount of serious adverse events and hospitalizations that are associated with medications. And that trend continues even steeper beyond 7 or more medications. So after 4, you see a sharp increase in hospitalizations and serious adverse events, which is likely why Europe has defined 5 or more meds as being polypharmacy. And then after 7, you see again another increase, and likely contributing to why we're seeing 9 or more meds being the acceptable the standard definition that we're using here in Fraser Health. Polypharmacy, if you don't think about it by the number definition that InterRI is reporting to us, polypharmacy really just boils down to any medications that might not be indicated or warranted in a patient at any given time. That might be 2 medications is too much for an individual like myself, who's generally healthy with no medical conditions, and 10, 11, or 12 medications might be necessary for the more complex and acute patients that we're now seeing in long-term care. Patients who have hepatotoxicity, patients who have pulmonary hypertension. I'm seeing a lot more complex and were not normally managed in long-term care setting previously. There are not a lot, but there are a few established evidence-based deprescribing guidelines that are available. The obvious place to start for me is looking at medications that have low doses, or if there are conflicting use medications. I don't have the same training as a physician as you as a prescriber. My training in pharmacy gives me the lens. My equivalent of a head to toe assessment is to assess 8 different types of medication related problems. So I'm looking is there an unnecessary drug, a drug that's no longer needed? So common examples might be a cream for a rash that has resolved, or a painkiller post surgery for a hip replacement. Something that's a self-limiting, they'll need that analgesic for 2 weeks, 4 weeks, but then it could be gone if they had no pain prior to that. Could be considered to be gone. I'm looking to see, is there too much of a correct medication? So often this might be somebody is taking blood pressure medication at too high of a dose and they're getting some low blood pressure. So we can just back off the dose of that blood pressure medication for them. I'm looking if there's too little of the correct medication. And so many times what I'll see with this is what I'm talking about here, these low doses of medications. So we'll see multiple low dose blood pressure medications, multiple low dose laxatives. Somebody's might be on 1 tablet of Senicides, 15 mils of lactulose, and they're taking Pegalax. So we've got 3 medications. A third of this resident's polypharmacy might just come from treating their constipation. Could we look to maximize some of those laxative regimens to decrease the number of medications that patient's taking for that? I'll see this sometimes with sleep medication. So somebody has started on a very low dose of melatonin. It's not working to help their sleep, so maybe it goes up a little bit, but we have this tiny dose, melatonin 3, maybe 6 milligrams at bedtime. They're still not sleeping well. So we add a low dose of atrazidone, or we add a low dose of mirtazapine, and you can see the prescribing cascade slowly go from there. I might be looking to see if there are drug interactions. So if somebody is taking iron and calcium at the same time, it's just going to clump up. They're not going to absorb either. This can be managed by spacing it, or it could be managed by discontinuing. All of their lab work is going to be reflective of them not having that medication because they've had this interaction. I have seen patients taking medications for conflicting uses. So you have somebody with hypothyroidism, they're started on Synthroid, but they're concurrently taking methimazole for hyperthyroidism. I'll see patients who are taking blood pressure medications, but also have a midodrine or domperidone on board. Patients who are taking laxatives, but then they're having some loose stool and they're started on cholestyramine. So these are areas that are very easy to clear up some of the number of medications that somebody might be taking. I'm looking to see, are there adverse drug reactions? I'm thinking, is the edema of this resident caused by a calcium channel blocker? Is their anticholinergic burden considered to be great because they're taking a number of different anticholinergic medications? I'll consider adherence issues. This will come up. You have nurses telling you it's really hard. It's really hard to instill eye drops for this resident. So is that a person we want to continue 3 different glaucoma eye drops for, or could we try and pick a combo glaucoma eye drop and leave them with one? The other part I'm looking for is there missing drug therapy? So quite often for me with this one, what I'm seeing is a diagnosis of asthma or COPD or emphysema, and this particular patient has no inhalers on board. Vitamins and supplements are the other area I would target, again, as being hopefully an easier area to eliminate some medications. Where this can be difficult, and I, as a pharmacist, need your help as a prescriber, is explaining some of the dubious health claims that homeopathic or naturopathic or herbal products might make. Families may have been convinced that by taking coenzyme Q10 or other selenium, cobalt as supplements, that they're improving their loved one's health. I like to reframe or rephrase that by saying those medications, if they do have a benefit, it's likely over a longer time. And we're talking about your loved one being in long-term care. Hopefully we're taking a palliative approach to their care. We want to keep them comfortable, not experience any side effects, not experiencing any pain, but giving them coenzyme Q10, selenium, or cobalt. None of those medications are going to improve their quality of life. Again, not always is that effective. Even with your input, you'll get family members who want to continue them, but these are ones that I would start looking at. Medication reconciliation. What I'm seeing with this is somebody's been admitted to the hospital, they come out, pharmacy or nursing staff have completed med rec, and what they've done is they've indicated to you as the prescriber that the Voltaren MU gel BID PRN for pain was discontinued. The low dose Zopiclone was discontinued. Their for you and said, do you want to restart? Yes or no, for you to give a tick mark. I believe it is an opportunity to leave those medications discontinued, not to restart them and add them into the conversation for polypharmacy, because many of those we can already monitor for. So what is that resident's, what is that patient's blood pressure? We don't need to just restart Ramipril. How is that resident sleeping? If the nurses haven't gone out of the way to tell you anything, it's very likely they're sleeping well without that Zopiclone. That salbutamol PRN was unlikely to have been used for quite a while. Maybe it was a leftover from a cold or flu. I mean, we've had COVID, so could be left over from an event from there. So not immediately restarting medications on a hospital discharge when you're seeing the med rec is another way to help keep some of the medications down. Look to medications that have established deprescribing guidelines. You may feel more comfortable making these decisions when you have evidence to back you up, when you have a nice algorithm to back you up and explain exactly what to look for to nursing staff and to families as to what they could expect if that medication was doing something important for their loved one. So the 5 different areas that have deprescribing guidelines or algorithms on deprescribing.org are antipsychotics, which I showed you the example of earlier, PPIs, anticholinesterase inhibitors, memantine, antihyperglycemics, and benzos. So we can look to all of those. For the purpose of time, I'm not going to go much further into these, but all of these have established evidence-based deprescribing guidelines. The other evidence-based deprescribing guidelines are through something called the STOP list, which stands for Screening Tool for Older People's Potentially Inappropriate Prescriptions. So it does a head-to-toe approach, goes through the different systems to give you, to ask you questions, to stimulate you to think about that patient and when you should feel comfortable discontinuing medications. It's been added on to include START criteria, which is the opposite of a polypharmacy approach, but may be in the best interest of patients. And ultimately, that's what you're looking for. Beer's list of potentially inappropriate medications in the elderly. These medications are medications that are most commonly associated with serious adverse events and hospital admissions. So looking at these ones may save us issues moving forward. How prescribing can change. So if you are writing for a self-limiting condition, I would encourage you to write a stop date or a discontinue built into that order when you first order it. I've used a Ventolin example here. If somebody has a shortness of breath or cough, I've ordered it regularly. In this case, it's likely there would be a PRN after that QID, but say for something like 1 month, if somebody, or 2 months, whatever's reasonable for you. But if somebody has shortness of breath or cough, and we think it's associated with let's get it discontinued without any additional input from pharmacy or your end. Add that 1 month, 2 months, and then stop. If you're prescribing a polysporin, a Fusidin, a Bactroban for skin tears, write for 7 days, 14 days, 3 weeks, whatever's reasonable for you. If you're prescribing a antifungal cream, again, you'll see my example here. I've included the area of application because with long-term use, I've seen it originally ordered for, say, an abdominal fold, and soon the nurses are applying it to somebody's feet the next time we're talking about this at a care conference. Quite often I'll see this one written as or until resolved, and I think that's smart because it may take longer than 4 weeks to treat that superficial topical fungal infection. And that way you don't need to be approached about this same problem again in 4 weeks' time when the nurses say it fell off the MAR, but they still have a little bit of an issue. With that being said, I refer back to the culture of the homes or the facilities that you go to. Some places have very strong staff that will do those follow-ups and will notify pharmacy when the area has cleared or resolved so that pharmacy, without your input, may remove that from the MAR. Other places, though, until resolved, and this medication will continue forever and ever and ever and ever. Again, similar to the antipsychotic use, if you indicate for what reason a medication was started, occasionally this can give us some clues into discontinuing these medications in the future. So if you're writing for post-fracture pain, we know that that's not a general osteoarthritis where maybe long-term analgesics may be warranted. Additional considerations, clinical pearls in here, if you will. Going back to the general course of our patients, many will develop dysphasias or have problems with swallowing. So can we look to some of those do not crush medications before they have problems and the nurses are sending you these urgent changes or urgent SBARs to change somebody's medications? Consider medications. So this was based off of a case that I experienced recently and had not come across before. An individual was taking higher doses of venlafaxine. They were on 225, I believe. Venlafaxine at higher doses is associated with quite significant withdrawal effects. Patients describe it as a shock-like sensation moving from their skull to their tailbone, and it's quite uncomfortable. Patients who miss doses coming into the pharmacy or they were not able to, again, this is a community patient, but if they're coming into my pharmacy, they're describing that they are very uncomfortable once they've run out of their venlafaxine. So we're talking about a patient who's taking venlafaxine at a care conference. Maybe they're on a higher dose, like a 225 dose, because this was prescribed 10 or 15 years ago prior to when they were in long-term care. We've just never reassessed that particular dose for this person, whether that dose is still the right dose for them. When they become NPO at end of life, there was this situation where an individual was experiencing significant discomfort that was likely associated with their sudden discontinuation of venlafaxine. That goes, continuing to speak on that about high doses of medications. As our residents continue to age and become increasingly frail and have all the associated changes in their body that come with aging, there can be a very slow and insidious onset of non-specific side effects. And this makes your job as a clinician or my job as a pharmacist quite a bit more difficult later to tease out what medications are contributing, where did the prescribing cascade originate, how can we unravel this? Some medications at higher doses will lose the intended effect of the medication. So I'm going to use mirtazapine as the example. If we're to stimulate appetite, to help with sleep, or to help generally, I'll call it mood, not a specific. Did I cut out for a second there? I'm hoping.
Just for a second, yeah.
Okay,
and
thank you.
actually,
Go ahead.
There's a question in the chat before we move on.
Oh, sorry.
To
Thank you.
No,
I don't
no,
have that
that's
open. Please
I
read.
know. I figured you might not. This is the first one, so I figured this is a good chance for me to butt in.
Yes.
It's from Dr. Mark Blinkhorn. He says he has patients who will have withdrawal effects. Sorry, I have patients who will have withdrawal on 75 milligrams or less of Effexor.
Absolutely. In this particular case, venlafaxine was a very high dose for this individual, which is what gave me a lot more confidence in explaining these very uncomfortable effects. If we are looking to discontinue venlafaxine before it is an issue, before somebody is end of life or actively dying, I would suggest going all the way to 37.5. And even if they're having continued issues, you go every other day for a week at the 37.5 milligram dose, every other day for a week or 2 weeks to make that to make those withdrawal side effects as minimal as possible. The last point I was going to make about mirtazapine is that when we're using it for appetite stimulation, the appetite stimulation is not dose dependent. So if they're going to have an increased appetite from that medication, you'll see it at that 7.5 milligram dose. If we are using mirtazapine to help somebody sleep, you will see them sleeping. If you're going to get that effect, you're going to see them sleeping at the lower doses, the 7.5 to 15 milligrams. Beyond 15 milligrams, it has less of an effect on sleep. You'll lose the drowsiness side effect the higher you go on mirtazapine. There are common barriers to deprescribing. Absolutely, you may need to restart a medication. I am less confident at medication reviews, making recommendations surrounding medications like herbal products, because oftentimes those medications are at the request of family members. That does not mean that there are not strategies like saying, my plan is to discontinue this medication if family is in agreement. And I, as the pharmacist or the nurse, can be delegated to make that phone call, explain the rationale to family, and hopefully get that okay to discontinue that medication. There's a lot of hesitation, particularly surrounding medications used for behaviors when you're trying to discontinue those from care staff. And of course, it's going to take a little bit more time. Instead of just drawing a line down your the pharmacy's prescription request for you and saying continue all, it does take more time to say decrease to this for 2 weeks and then decrease to this for 2 weeks and then stop. So there was a few questions that have been sent in. I want to try and tackle those for you now. The ones that I felt I could try to fit in, and I realize I'm running time here, is using metronidazole, aspirin use, everyone's favorite statins in long-term care, and then looking at B12 or vitamin D. In the interest of time, I don't want to keep you too long, so I might be going too fast. Please slow me down. When to use metronidazole powder on wounds. So there is, if a wound has a distinct malodorous smell that is distressing to either the patient or to family member or to caregivers, absolutely you could consider using metronidazole on the wound to decrease that wound odor. There's not a lot of evidence to suggest that doing this will improve the speed of healing, but it has very good evidence. 94%, 5 out of the 37 people who had metronidazole sprinkled on their wounds saw a significant reduction in odor of the wounds. So 94. I most often see this in a hospice or palliative care setting, not as often in long-term care, but I see the use for it in long-term care if you had a chronic or a malodorous wound. The majority of the studies use the Metro Gel or Metro Cream, but more and more evidence is suggesting that just sprinkling a 500 milligram tablet over the wound for in the area of 5 to 10 days should be of benefit in decreasing the smell coming from these wounds. They were studied anywhere from 7 to 14 days. From 5 to 14 days. So anything in that range would be a reasonable length of time to use it for. And you would see the benefit quite quickly. If after 2 or 3 days, there's absolutely no difference in the smell, you're not going to notice a benefit in the smell. The most common side effects were skin irritation or a burning sensation. Nitazole onto the wound, there was almost no systemic side effects, suggesting very little absorption. So there was no nausea, no gastrointestinal diarrhea side effects associated with this. That would also mean that if somebody has an infection or a deeper wound that you wanted to treat suspecting anaerobe involvement, then you would use oral metronidazole rather than a topical one. Statins in the elderly has been a question for many years. Statins in long-term care as a part of this question has been around for a very long time. Therapeutics Initiative has put out some good worksheets or good summaries of the evidence over the years, and there's at least 3 that have tackled this. The most recent one is roughly about a year old and is summarizing again that the takeaway message from this should be for primary prevention, do not recommend statins for use and discontinue it for primary prevention. Statins can reduce serious cardiovascular events. So if you treat 71 patients with a statin over 5 years, you'll prevent 1 event for them. What was interesting when going through the meta-analysis in the Therapeutics Initiative, we'll do a lot better job at describing the intricacies here. What they saw was that there was a decrease in serious cardiovascular events for primary prevention, but not a decrease in total serious adverse events. A serious cardiovascular event would also count as a serious adverse event. So if we were decreasing serious cardiovascular events, we should have seen an associated decrease in total serious adverse events. And because that was not spotted, they're speculating or postulating that statins increase the risk of other serious events that would then negate this benefit, this cardiovascular benefit. Where it's more nuanced is with secondary prevention. So we know statins have a proven effect here. So the relative risk of death, absolute risk reduction of 1.3% and an absolute risk reduction in serious events like a coronary event or stroke are decreased by 4.4% in this case. So the number needed to treat there, if we were using it for death, so if you treat 77 of your patients for 5 years, you will prevent 1 death. And if you treat 23 of your patients for secondary prevention of heart attack or stroke using a statin for 5 years, you will prevent 1 heart attack or stroke. There is further investigations going in. A lot of the flaws here are that the data being collected, they have not separated primary or secondary prevention. A lot of the data is for individuals who are 70, 75, in the 70s are the oldest that we're seeing these patients in studies. There's really not a lot to give us evidence for anybody 80 or beyond. 80 is sort of my hard rule for when I will start forcing that conversation a little bit more. But the insight seems to be you could make a strong case that even in the 70s, getting rid of these medications. Again, it's nuanced. This would be where having a conversation with the family could be important. The other consideration, so there is these further studies that are hopefully going to provide some additional insight to us in a more patient-specific population that we would see in long-term care. What's coming from that, the early release from these studies is that statins have not been proven to increase survival in a combined population, so meaning primary and secondary prevention again, and we know primary prevention, we shouldn't be using it, so maybe that's not surprising. And that this absolute risk reduction that I was talking about for death and strokes and coronary events, it is not as the reduction in the relative risk is not as big in secondary prevention when we're using it in the population we are talking about in long-term care. I know this is very brief. That's the fastest takeaway message I can give you for statins. Do not use them for primary prevention. For secondary prevention, 70 to 80, have a conversation. Beyond 80, I would feel pretty comfortable in saying discontinue statins. Baby ASA use and GI bleeds. I picked this start and stop criteria to answer sort of what I felt was the immediate takeaway message from this question, or what was being looked for. And that is that if anybody has had any peptic ulcer disease at any time, if it's active or recent, then if they needed ASA, they should take a PPI. If your bleed risk is felt high, that is somebody who has uncontrolled hypertension, if they've had recent bleeds, those people should have their anticoagulant or antiplatelet discontinued. I don't know if anybody is familiar with a tool that I've started to use more now called the Spark tool. It's at www.spark.com. If any of you have your screen open and can go there, you can do this in under 1 minute. It did not work well for me when I was practicing it earlier, so I did screenshots instead. So I want to walk you through quickly. This is something that I could do for you at a care conference in under 1 minute to give us some quantifiable data to talk to about families with respect to, in this particular case, it's patients who have atrial fibrillation. If a patient has atrial fibrillation, I'm talking about stroke prevention here. So when you join the website, it'll show you these two here where you can very easily click on any of the risk factors. So I'm imagining a 76-year-old female who has had a stroke in the past and has controlled hypertension right now. This individual has no additional risk factors for bleed. So we can see their CHADS2 VASC score there and their HAS-blood score. Then it will show you this type of a screen here that's showing you that individual, that 76-year-old female with a history of stroke and controlled hypertension, if we do not treat that individual, they have an 11% chance every year of having a stroke. If we do not treat that individual, they have a 0.4% chance of bleed. Different, all the aspirin, like apixaban at the bottom, which has I think I went unstable again. I hope I didn't miss too much. I want to highlight apixaban at the bottom, which has the greatest reduction in stroke or embolism risk and the least increase in bleed risk. For this reason, this is pretty strong evidence. And so PharmaCare no longer requires you to apply for special authority to have these medications be covered. So for that reason, we're seeing a lot less warfarin. If you use an EMR system, this website will continue to let you copy and paste this if you wanted to put something into your EMR, or if you wanted to copy and paste something for electronic progress note. And then it gives you a graph such as this. I just picked a apixaban, but will highlight the relative risk reduction, absolute risk reduction, chance of benefit, chance of major bleed. So it may be a benefit to explaining to families if your loved one is taking apixaban right now, they have for 12 patients you treat who are taking this, you will prevent 1 stroke. And for the if you treat 41 patients, you'll have 1 bleed. So the evidence would suggest to continue that treatment. But again, we want to align this with the residents' goals of care, and we have to consider it through the long-term care lens. Vitamin B12 and vitamin D supplementation should not be, but can be difficult. Vitamin B12 levels are often low in elderly residents, and there are numerous reasons what we might see that. If they are vegetarian, if they were admitted to long-term care with a failure to thrive, if they have pernicious anemia, atrophic gastritis, if they're taking medications like metformin or a PPI. Now, where I wish you good luck as a clinician is the symptoms of B12 deficiency are very non-specific and basically describe all of our patients in long-term care. So symptoms of B12 deficiency can include confusion, weak muscles, numbness, trouble walking, nausea, weight loss, irritability, fatigue, and increased heart rate. Think of any of your patients in long-term care, and the majority probably have a number of those. It can be difficult to assess because symptoms of deficiency are not correlated with the severity of deficiency. And we know even if an elderly person is in the low end of normal, they could also have associated symptoms with that. Previously, I had always suggested discontinue because I had a palliative approach to care in mind. And my rationale was that this B12 is not going to improve this resident's quality of life. There was Jerry Rounds at VGH less than a month ago, and one of the geriatric residents did a talk on B12. And the takeaway message was basically, we should be doing B12 for everyone. I don't know how that aligns, everyone in every elderly resident, and I don't know how that aligns with a polypharmacy. So if I try to think about it critically, I would say consider continuing vitamin B12 if you have somebody who has a condition that's going to make that the case. If you have somebody who has a long-standing alcoholism, if there are multiple risk factors, or in your case, maybe you've got this documented deficiency. So somebody's ordered a B12 level and it's showing up as being subtherapeutic. You can convince me to treat this patient because there's very minimal toxicity associated with supplementation. It's safe, it's unlikely to contribute to any poor effects. Some strategies to help with polypharmacy. Again, trying to think as critically, we want to help our patients. How can we do this quickly in a long-term care polypharmacy world? If that's the case, you could consider repleting your patients in sort of a more rapid manner. So whether that means giving them IM injections. I've seen physicians order the same day shot to the left delt and the right delt, an IM injection to try and help replete their patients. Could you order B12 for a defined period of time again? For 3 months, then discontinue. For 6 months, then discontinue. I still do want to take a palliative approach to care in a long-term care setting. And so for many patients, I would recommend discontinuing. And I think you should feel comfortable discontinuing it. If you have patients, if you have staff, if you have dietitians on your team who feel very strongly the other way, it's nuanced. We can talk further about that.
Matt, there's a question here. What about B12 and metformin?
Yeah, metformin will decrease the absorption of B12. What I think is an important takeaway here is that if you were to stop B12 intake entirely, your liver has stores of B12 that will last you anywhere from 5 to 10 years from completely stopping to take vitamin B12. So it's reasonable to think that by the time somebody's ended up in long-term care, there's been some issues for them. Maybe they've had a failure to thrive. Maybe they've had a lot of these other issues. Maybe they've had metformin for more than 10 years. So you could convince me that those patients should be taking B12, and I wouldn't press the point too much. I would also suggest that if somebody is going to live for 1 year or 1.5 years in long-term care, whatever our average length of stay is now, I would also argue that the severe effects of B12 deficiency, when we talk about it affecting causing neurological conditions, those symptoms are irreversible. So if you've had somebody with alcoholism, if you've had somebody with these issues in the community, and this has gone on for long enough, and we think their behaviors are being caused by a low B12, giving B12 may not resolve that. It could be irreversible already by the time you see them in long-term care. Hopefully that answers the question. I included some very brief slides here on different repletion or treatment modalities. Again, in the interest of time, I don't want to spend too much time here because I would like to also talk to you quickly about vitamin D. I was involved in a debate where I was debating vitamin D should not be being prescribed in long-term care. So the next few slides will have my bias built into that. And so I might sound wishy-washy because I'm going to argue what my opponent was arguing as the flaws to what I'm suggesting. So the context for the discussion is that in the early 2000s, Surrey-North Health was asking you to prescribe vitamin D 20,000 units once a week for all your residents. The goal was to decrease falls, decrease fractures, and improve non-skeletal outcomes. Back in 2013, they decreased it to the recommended dose of 10,000 units once weekly. And in July 2018, they discontinued that entirely. I've seen many of us move towards if they're non-mobile, let's stop it. And I like that approach. But I want to review the evidence now for the different suggested uses. So if you're going to use vitamin D for falls prevention, what is the evidence? The best one I could find to summarize this for me was this study here, effects of vitamin D supplementation on musculoskeletal health, systematic review, meta-analysis, and trial sequential analysis. This included 81 different randomized controlled trials, but falls prevention lens, 31 of those trials reported about falls. Those 31 trials had vitamin D as a supplement, low dose or high dose. They were considering less than 1,000 units as a low dose and more than 1,000 units as a high dose compared to placebo. What the authors of this meta-analysis had determined was that what their summary conclusion was is our findings suggest that vitamin D supplementation does not prevent fractures or falls or have clinically meaningful effects on bone mineral density. There were no differences between the effects of higher and lower doses of vitamin D. There is little justification to use vitamin D supplements to maintain or improve musculoskeletal health. This conclusion should be reflected in clinical guidelines, which is a pretty strong statement. Clinical guidelines take a long time to change. So right now, we still follow clinical guidelines. And if you're going to do that, to give vitamin D to decrease fall risk, it was accepted that 1,000 units was the dose that you should use. This is, I would suggest that 1,000 units for fall prevention if you have community dwelling older individuals who are nervous or concerned about these sorts of things. If we talk about vitamin D for fracture prevention, you can look at this study from the New England Journal of Medicine about a year ago, supplemental vitamin D and incident fractures in midlife and older adults. So what this was a ancillary study that tested the question of whether supplemental vitamin D would result in a lower risk of fractures. So they looked at 25,000 approximately 25,000 patients. They did not include patients. They did not have a recruitment of patients who might have a vitamin D deficiency, low bone mass, or osteoporosis. So if we think about long-term care, our patients likely would have those. It doesn't mean those patients were excluded in these studies, but they weren't selected to be a long-term care representative population. So they either got 2,000 units a day or placebo. There were 769 fractures in the vitamin D group and 782 fractures in the placebo group. They determined that vitamin D supplementation did not result in significantly lower risk of fractures than placebo among generally healthy midlife and older adults who were not selected for those criteria previously mentioned. Again, they specifically say amongst generally healthy midlife and older adults. But if the evidence is suggestive here, I believe it's not the best medicine. I believe you can extrapolate this and make a case that in long-term care, we wouldn't expect to see the complete opposite of this. I looked at, there's not much to look at when it comes to taking vitamin D for for extraskeletal health. So there's currently no convincing randomized controlled trial data that suggests that vitamin D supplements can decrease cancer risk or prognosis, decrease the risk or severity of infections, diseases, or decrease your cardiovascular or metabolic diseases. There's a large number of epidemiologic data that has these associations, but nothing in a randomized controlled trial that has strong enough evidence for anyone to feel comfortable making this a strong recommendation moving forward. So I would not take vitamin D for extra skeletal health. So then we consider the problem, well, it's just vitamin D. What's the harm in continuing this for our patients? So this study came out in 2010. It was annual high-dose oral vitamin D in falls and fracture in older women, a randomized controlled trial. So this was interesting in that they studied approximately 2,000 women over 3 to 5 years who received 500,000 units of vitamin D as a single dose once a year or placebo. To hear 500,000 units once a year sounds absurd. But if we are giving our patients 10,000 units weekly, and there's 52 weeks in a year, they're receiving 520,000 units in a year, which is comparable, not given the same way, but is comparable to the dose that they received in this study. The outcomes, they found that giving vitamin D increased the risk of falls and increased the risk of fractures. So if you want to give vitamin D at a lower dose for a osteoporotic patient, and you're going to use an 800 to 1,000 units once daily, many homes are going to ask you to switch to the once weekly dosing to try and prevent decreased pill burden, decreased nursing time for administration. So if they're going to be asking you to change to a 10,000 units once a week, already you can get into the discussion of that could potentially be causing harm for our patients. At the end of the day, like I'm saying, I hope I'm not being too wishy-washy, because a lot of this is nuanced and every patient needs to be taken into account individually. A lot of them have, many of our residents in long-term care will not be able to speak for themselves. So we're relying on family members saying essentially what their wish for their loved one is, which might be different. So person-centered care, this informed shared decision-making approach, recognizing, acknowledging that our long-term care population, we have frail patients with advanced disease and limited life expectancy. So taking a polypharmacy, through a polypharmacy lens, through a palliative approach to care, do I believe that vitamin D or vitamin B12 supplementation would improve my patient's quality of life? Many, I would suggest it would not, and would suggest to discontinue. Any other questions? I went really quick towards the end to try and get us to finish on time here.
So do you have time for questions, Matt?
Yes, please.
I was trying to chart, but I can answer. So vitamin B12, and when we measure in a serum level, does serum level reflect actually body storage? Do we know that?
So there are additional markers that you could look at if you truly needed to determine whether B12 was contributing to some of, if you were trying to be the detective and take your long-term care patient and truly determine whether B12 was contributing, you would measure other levels, the homocysteine level, these markers, to help you determine that. If somebody, a circulating B12 level, it is variable. It is not the best marker for that. If somebody has liver damage, again, it's being stored in the liver. So if we have somebody who has elevated liver enzymes, they may likely have an elevated B12 level as well, because as the liver is being damaged, it's releasing more stores of this. So it's not the best marker. There are additional laboratory or diagnostic markers you could use. I will not speak to that for this, but I will share that link again from that geriatric resident who had done the B12 talk. She went into quite in depth. I mean, it was a 1-hour talk, and all of it was spent on how you as a clinician would determine B12's role for your patient.
Okay, thanks. If nobody is asking, then how about the Spanish study at the first year of COVID, and they used the intravenous vitamin D on those already admitted sick with COVID patients. There was, of course, not a elderly population as in long term, but then in their study, it was apparent benefit of intravenous vitamin D. Any comments?
Right. it is usually correlation or associated, and very rarely will you find or ever find strong evidence to make a strong recommendation surrounding that. I believe that you are not wrong if you are looking for any avenue to help your patients and to protect your patients. You wouldn't be wrong to follow some of those associations and think there's not a lot of harm with vitamin D. Should I prescribe vitamin D for this patient and potentially prevent some COVID complications or COVID severity for them? You could convince me of that, but I challenge you, in the era of polypharmacy, and we're constantly getting our feedback that our numbers are too high, our polypharmacy is too high. In the era of that and thinking about this, is vitamin D going to make a significant difference for that patient? When COVID first came out prior to the boosters, and it was scorched earth in long-term care, would providing our frail, sick, long-term care patients with vitamin D, even if the symptoms were a little bit less severe, would that have been enough to save their life? We don't know the answer to that. Would it decrease the severity of some of their symptoms? Potentially. That's what some of these associations were suggesting, but there was nothing that was definitive or strong enough for any governing body, prescribing guideline to suggest using it empirically without any thought put into it.
Oh, very eloquent, Mark. Thank you.
It's nuance. You can convince me either way, and that's why I hope to provide some clarity to it. But at the end of the day, we're going to have these conversations, these back and forths, and if that can be done quickly, to summarize for a family member and have them give us a yes or no answer, we can feel more comfortable if that's what it is to make us stop it.
Matt,
Yeah.
What do you say to the families who believe and the doctors who believe that statins can actually give more benefit to the older they are? And and who's going to benefit more by these statins other than the real old people that need stabilization of the blood vessels?
Right. So what we don't know from studies, from randomized controlled trials, is how this is working in a greater than 80 years old. There's almost no patients enrolled in these studies. When we look at these studies and they're suggesting these benefits, quite often they are excluding the patients that we would be seeing. They're excluding multiple morbidities, older, frail individuals, because they don't want people to be passing away during their studies, skewing results. So I would suggest, and Therapeutics Initiative speaks to this as well, that the benefits that we see, we think to me, it makes sense to think these are the sickest people, so they might get the most benefit from these medications, have a benefit. But we're actually finding, if you dive into the statistics, that it doesn't seem to be the case, that these benefits we talk about in reducing death and in reducing events are not as large in a long-term care population.
Yeah, I'm all for stopping it too, because the benefits of the statin will still probably last for another 5 years after you stop it anyway. So yep. I'm okay with stopping it. But I was talking to a college investigator, and he was saying the opposite. That there's evidence out there saying that the statin should be continued in this age group because they're the ones who are going to benefit from them more. And just because they're old, they shouldn't be denied that. And that's what the cardiologists are saying now.
Yeah,
so what do you do?
Yeah, I think you hit the nail on the head there with, I have a general bone to pick with cardiology. Any of your patients who have a heart attack and end up in the hospital will get the same treatment that your 40-year-old patient will get, with the same goals listed by the cardiologist of increasing their ACE inhibitor, of increasing their beta blocker, of giving them a high dose statin, not even a low dose statin, and of giving them anticoagulant therapy. I think it's incredibly difficult to study in this population, but I believe that I hope to see during my career where some of those considerations are put into place for long-term care now, because it makes your job more difficult. It makes my job more difficult to make these recommendations when they saw the cardiologist a year ago prior to after their heart attack that they ended up discharged to your long-term care facility. It's difficult. You have now the specialist suggesting, well, keep them on this high dose statin. One approach I've taken that can help is, so if they come in and they're on 40 milligrams of atorvastatin, well, let's go to 20, let's go to 10. And the next time we see them, let's stop it then. So over the course of a year, we've gotten them off of it. I agree with you. These benefits are going to be prolonged, are going to not cease immediately upon discontinuation. So if our residents are living 1.5, 2 years on average in long-term care, then I feel that we've covered that area for them.
Good. Well, I'm glad I'm on the same wavelength.
I'm glad I'm on the same wavelength.
It's all about goals of care, isn't it?
It really is. And I think the informed shared decision-making process is important. And sometimes it's actually been very helpful for me in a polypharmacy approach, where it's the family saying, well, let's stop their Tylenol, let's stop their painkiller, let's stop their antidepressant, let's stop these things. Sometimes that can be really helpful instead of me sitting on the fence, humming and hawing, saying, and sometimes feeling not as comfortable to make those recommendations, knowing that if things go sideways. So for example, I'll use vitamin C or cranberry capsules. Yes, let's get rid of them. There is not evidence that they are going to decrease urinary tract infections, but we're talking about old people who are susceptible to UTIs. So if I, as a pharmacist, I'm recommending to discontinue cranberry and PeriCare wasn't super well done a week from now and they get a UTI or they get another UTI because they're getting them anyways, the family quite often believes that was my role in saying stop that caused that UTI.
You're always looking for somebody to blame, and it's always because this person's not drinking enough water. Just increase that. But these people don't drink water, so it's pretty hard to do sometimes.
Absolutely.
I've been trying to think of ways of doing it, but it's pretty hard. I wanted to get those helmets that people have in football games with the water bottles on either side.
Yeah, little drinking straw.
They're too heavy for these people. They can't use them.
All right. Are there any other questions? Okay, cool. Thanks, Matt.
Thank you very much. I'm going to exit from the talk, but Harv, Andrew, Marie, they all know how to get a hold of me if anybody wants references, has additional questions. I'm happy to talk. Thank you, everyone. Thank you very much.
We got copies of the slides.
Thank you so much, Matt.
Thank you.
Thanks.